Good evening, everyone, and welcome to the online shoulder and elbow school. Today's session focuses on revision surgery in shoulder instability. We have an international panel with 2 senior surgeons and 5 junior surgeons. Our senior faculty will present clinical cases, which we will discuss together with the panel to explore decision-making and treatment strategies. It is a real pleasure to have with us today 2 well-known experts in this field, Dr. Abdulilah Hachem from Barcelona and Dr. Ruth Delaney from Dublin. Our junior panel today is formed by Ameer Aldarragi from UK, Nekati Bahadir from Turkey, Blanca Diez from Spain, and Vinay Samant from India. So without further delay, let's get started. We are going to start with the case presented by Dr. Delaney.
Thanks so much, Juan, and thank you to CESIC for putting these really valuable sessions together. It's great to get to interact across, across the generations now. So both Hashem and I are going to talk about failed shoulder instability, and we have a case each, some similarities and some differences. So I'll start, and we can discuss this as we go along. So here's the history. Very typical in my practice in this country. 21-year-old professional rugby player, and he plays elite Gaelic football sport as well. By the time he came to see me, he was now playing full-time professional rugby. Had a first-time dislocation of his non-dominant shoulder, making a tackle in a rugby match. It was reduced. He played on, but he really felt he lacked confidence in the shoulder and started rehabilitation straight away. Only 2 weeks after that, he came to see me, and he was already feeling a lot better. So doing pretty well. This guy has access to intensive high-level rehab. So he does have anterior apprehension, Gauge sign, relocation sign. But overall, he's feeling better. So I guess at this point, maybe I'll start with Ameer. You're the first name that pops up. What are you thinking in terms of your imaging for instability? What do you like to use for these patients?
Yeah, so first of all, thinking about the case, obviously you've got a young sports person who's involved in contact sport, so it puts their risk of redislocation as quite high, even though he's, like you say, his clinical examination is pretty good, but that's likely because he's rehabbed so well, so quickly. I think, my first line investigation for a person like that would be an MR arthrogram, and that will provide invaluable kind of evidence towards his labrum and how that's doing and other things.
Yeah, I agree 100%. So that's really what it comes down to, isn't it? It's these guys' risk of recurrence. So he wants to get back to contact training and matches, and he wants to know sort of what are his chances of making it through the season? There's still 4 or 5 months left, or should we do something now? So just like Amir suggested, I've got an MR arthrogram at the time. So um, looking here, we can see the anterior labrum is torn. He doesn't really have any glenoid bone loss. He's got this big, deep Hill-Sachs lesion at the back. So we'll let that axial scroll through again and just see. And then I think the other thing that, we pretty much know the labrum's going to be torn. So a lot of the time we're looking at the bone to decide which procedure. So I think a CT is also CT arthrogram is also an equally reasonable consideration. It depends on your country and your system, I think, which is easiest to get. These are the coronal views. Again, we see that real deep acute Hill-Sachs lesion. And then we can also look for something like a Hagel lesion. Don't forget that if you have a humeral avulsion of the glenohumeral ligaments, that might also change your decision making. Um, so, Blanca, what do you think? Okay, you've seen the imaging now. We have a Hill-Sachs, no major glenoid bone loss, collision athlete, 21, one dislocation. In Madrid, what kind of procedure do you think you guys would lean towards for this patient?
I think for these patients, he has a high risk of recurrent instability. I think according to ICE's classification or score, he may have a 5 points, maybe I've calculated. And for him, we definitely recommend him going through surgery, maybe a Banca arthroscopic Banca repair, and see if the Hill-Sachs is engaging after that. If not, probably because he's a contact athlete, we would recommend him adding a remplissage.
Yeah, I think that's a good point, you know. So the options in these high-risk athletes, there's also the PIT score, which is recently published from Pittsburgh that Albert Lin and his group have published, and that helps you sort of think about soft tissue versus bony procedures. So, you know, you could say, okay, do we manage him conservatively, wait for second dislocation to happen before we operate? But we know there's some evidence that that may result in a worse outcome. But he's sort of feeling good and doesn't want to stop. So that's one option. The other option is, you know, operate no matter what, but wait till the end of the season, even if he hasn't dislocated, or go ahead and do it now, pull him out and rehab him. So he was still sort of thinking about it and leaning towards having the surgery. And then, of course, he dislocated again. So that made the decision easier. So we've talked about this. Is there a role for soft tissue procedure? And I think, you know, when you add the remplissage to your labral repair, that can often make your chances of recurrence much lower. Or do you think about a bony procedure because he's playing contact sport? And it's the sort of risk profile of the bony procedures and the complications versus the recurrence risk. So those were kind of the things I was thinking about. This is his arthroscopy. Just two still pictures, one looking at the glenoid. So the picture on the left, you've got humeral head on the left, glenoids on the right, and you're looking at the anterior glenoid, and then there's his Hill Sachs. So Vinay, what do you think about his glenoid when we look in the scope? Remember, he's had one more dislocation since his MR arthrogram.
I could see that there's a small amount of a really small bone loss, nothing significant, but it's a small bony chunk that I could see on the glenoid.
Yeah, I agree with you. So we didn't see that really on his first MR arthrogram, either because MR is not great for looking at bone or because he only damaged that in his second dislocation. So I did like my French friends would do, and I did a Latarjet. I did an open Latarjet because I guess my experience with these athletes is generally that they are at such high risk of recurrence. I would worry a little bit about that combination of the glenoid bone loss and the Hill Sachs and his collision sport. So this is 2 weeks, 2.5 weeks post-op. Everything looks pretty good. This is him at 17 days. He's doing well with his rehab. Usually I say 12 weeks because we need the bone block to heal and aim for full contact by 16 weeks, you know, bearing in mind with these professionals, you're sort of under time pressure. Hashem, what do you do with your Latarjets in terms of rehab? Do you sort of have similar timelines? Do you go a bit slower? Are we crazy?
Yes, you know, I'm not a fan of Latarjet, but sometimes I did Latarjet. I used only 2 weeks. I used to put thin in that times, and immediately started with range of motion. In your case, if you are using even 2 screws, with a good X-ray as you have demonstrated here, I will start it even at 10 days after surgery. With the patient feel comfortable, skin is good, no hematoma, and a scar is good. So it's good to start it at this week immediately for range of motion, avoiding the stiffness, avoiding the capsulitis, and but not, of course, not to return to play. Of course, we should wait to see at least in Bernard's view, the bone is healing, the graft is healing.
Yeah, I agree. So everything's going great. And the problem is that sometimes with these guys, they feel too good. So it's only 8 weeks, and I get a call from the doctor of his team. So yeah, he has some anterior pain after doing chin-ups the other day in the gym. So I did an ultrasound and his biceps looks inflamed. I think I'm going to get an MRI and inject his biceps. And I'm just like, no, 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 like stop. So my problem with all of this is, okay, first, what is he doing pull-ups or chin-ups at 8 weeks after a Latarjet? That's not allowed. Second, an MRI, of course, we know is not going to help because there's 2 big screws in there. We're not going to see a lot. And I don't want anything injected yet because I don't know what's going on with his graft because he's been doing these ridiculous exercises. So I said, okay, please get an X-ray, because a lot of the sports doctors that take care of the teams here, they prefer getting MRIs of everything, and they don't realize that X-ray is actually what we need. So Here's his x-ray after doing pull-ups at 8 weeks out from Alerge, which is not part of the rehab protocol. So I think you can see what's going on here. So what are you thinking, Bahadir, at this stage? You've got this professional player 8 weeks out, and he's been doing something he shouldn't have been doing, and now we've got this x-ray.
Uh, it's looks like something's like there's a piece over there, but I'm not sure what it is for now.
Yeah. What would you do next for maybe getting a better look?
So CT would be better option for us, yeah,
For
to see
sure.
what's
Yeah.
going on. And yeah, it's maybe coracoid avulsion or something like that. I'm not sure.
Yeah, you're absolutely right. So, I mean, if you think about it, right, the short head of biceps is part of the conjoint tendon along with brachialis. And you do something like this, you're potentially going to rip the graft off, especially if you do it at 8 weeks and the graft hasn't had time to heal. So basically, this was what happened because it pulled the graft off. So we got a CT and had a look at it. So he's pulled it off. What do we do now? And he, of course, is saying, well, it was sore then, but now another week, two later, it's fine. I feel good. So we checked the CT, just as you said, to see how much of the graft was left on his shoulder. We can continue rehab. What should we do about letting him back to play? He hadn't returned yet because he was only 8 weeks. Should we see what happens? So here is the CT. You can see that he still has that big acute Hill-Sachs lesion, or big sort of quite deep Hill-Sachs. The graft, the superior portion looks actually pretty good for 8-9 weeks. This might be kind of 10 weeks by the time we took the CT, but when you keep going down, you see that there's this piece of coracoid down in his axilla. So it basically ripped off from around the inferior screw. The screws are still there. So this is the question then. Do you insist on doing a revision now? Or do you kind of decide, well, maybe there's enough coracoid there. We've lost the sling effect, right? Because the conjoint is gone. So I don't know, Hachem, this is kind of a tricky situation. What would you do now at 8 weeks, whether it was a bone block or a Latarjet? I know it wouldn't happen, I guess, so easily with a free bone block, but what do you think you would do now?
It is interesting because you have Hill-Sachs lesion. What you didn't treat it, you have a skin effect is it could be now it's out as skin effect. So did you reattach in your usual current technique? Did you reattach the capsule to the
Yes.
remnant? Exactly. So this is maybe a good idea because she has reattached the capsule. If the capsule is there and only she redetached the conjoint tendon, could be we should wait and see 1 month, 2 months, what the feel of the patient, and then that we see what's happened.
Yeah,
Not
yeah.
to go
So,
immediately to revision.
yeah, I agree. So that's kind of what we agreed to do. He didn't want another surgery. It's at the important part of the season, so he wants to play. He feels like he's back on track with his rehab. So we took our chances and we see what happens. Finished the season, did well until the start of next season. And we discussed revising it in the off season. No, he felt good. So now, second game of the next season, he dislocates. I'm not particularly surprised because it's not really the Latarjet that I wanted for him. So he's now 6 months out. It's the start of a new season, and now we're stuck. So now we have a failed Latarjet with a repeat dislocation. So I felt we have to do something. Let's see, I'll throw it open to the floor. What do people usually do if their first procedure fails and if that procedure is a Latarjet? Anybody, Juan or Valentina, what do you guys think about this? Or any of the juniors, what have you seen done for a failed Latarjet?
Eden Ibinet procedure.
Mm-hmm. I think that's the classic approach, right?
Yeah, in my hospital too.
Maybe distal.
Anyone can consider to reattach that piece of bone with the conjoint tendon? I mean, is that a good idea? No idea? Remove one screw, open one, and try to reattach this same 6 months after? What do you think, all of you?
I think if you were going to do that, the time to do it is probably right away when it's happened. So this happened at about 8 weeks post-op. and he's now 6 months. So it's been about 4 months that thing has been pulled down. It's sort of retracted down. So one difficulty is stretching it back up. It's going to be scarred in there. And the other difficulty is where it's sitting makes me a little bit nervous. It's down, almost in his axilla. And if you think about what's deep to the conjoint tendon when it's in its normal position, it's potentially going to be close to the brachial plexus. The axillary nerve anatomy is a bit distorted after the Latarjet. So I think if you were to do that, there are some risks with it, and I wouldn't try it now. I don't know. Hashem, have you
Absolutely.
gone after that
Abs-
type of thing?
Absolutely agree with you, because in some cases, in failed Latarjet, you have the piece of bone there and you can reattach it immediately. But I'm pretty sure, as Ruth said, you should detach the piece of bone, release the conjoint tendon, release the even musculoskeletal nerve, the axillary nerve is there, and if you are 10 centimeters from the coracoid process, you have also the radial nerve. So there's many risks there. So don't do it. I think it's the best way. We'll see now what Ruth did.
I think that would, yeah, you could potentially make a bad situation worse here and have a really life-changing injury to a young guy. There are some other things that I guess other people have talked about, like Pascal talked at CESEC last year, I think it was, about using maybe the distal clavicle or the remnant coracoid, like the stump. Now, for me, I always take as much of a graft as I can, so there's not much coracoid left back up there at the proximal coracoid in front of the CC ligaments, but there are, I guess, some other options. And so this is exactly what we've just discussed. Would you go after that displaced piece of coracoid? And personally, I was a little bit too scared to. So yes, I went for just the classic Aden Hibinet open. And what's interesting is, we've always, I guess, traditionally thought of this as the revision procedure, but now as the advantages of free bone block procedures have become more studied and more recognized, there are people who will actually go to the iliac crest first. But so this is exactly what I did. So these guys both described it independently. And then I guess the German guy was a little bit more organized. He wrote it up pretty much within a year. The Swedish guy took him a few years till 1932 to publish it. But Gilles Walsh has published with John Lunn, his fellow at the time, 80% good or excellent outcomes from the Aden Hibinet for this exact situation when a Latarjet has failed. Other sort of similar 75%. But if you look at osteoarthritis later on, it's related to the external rotation stiffness. I think that's something we really have to work on avoiding. And also the longer you follow these patients. And I don't know if the OA is because of the surgeries, the Latarjet and the Aden Hibinet, or if it's because of dislocation arthropathy or some mixture of both. But this is him. This is, I think this might be a different case where I did the same thing, actually looking at it because it's a right shoulder, but taking the iliac crest graft first here. So measuring it, making sure you take at least a good 3 centimeters. You can always trim it down, but you want to take more than you need. This is how I prep it, just exactly prep and drape the shoulder as normal. I use an arm holder and I prep and drape the crest. Go get the crest first. Re-exposing after a Latarjet is something that's important to respect. It's not simple. And that's one of the criticisms of the traditional open Latarjet, of course, is that you're going to have distorted anatomy there. And the key, and this goes for just taking out Latarjet screws as well. The key is to go in and split the subscap again, open the capsule and put a humeral head retractor. In this case, I have a Triac retractor in there. You can also use a Fukuda. And then go from the glenoid within the glenoid surface out to where your block is and where your screws are. If you just dive straight in from superficial to deep, you could end up with the plexus or the axillary nerve between you and the screws. So that's something, even just if you go to take out Latarjet screws, to respect and be aware of. So thankfully, nobody was blaming the surgeon. His dad said, okay, this time I'm not going to let him be an idiot. So I did the iliac crest grafting. We got a CT to make sure it was healed. It's hard to tell on that x-ray. It's not a very good Bernagio view. It looks like my screws are all over the place, but actually the graft is pretty flush. And returned to play 14 weeks after the Aden Hibinet and went back to his career as a professional rugby player, thankfully. But it just shows you that when they get too excited about feeling good and they're in the gym, and I think it was him and a strength and conditioning coach, and they just went to town on it and did pull-ups, not thinking about the S&C coach wasn't thinking about the anatomy, or maybe didn't understand the procedure, that even the Latarjet can get pulled apart if it's too early. So that's my case. Hashem, do you have any thoughts you would add at the moment?
It's a good idea. I mean, if in fact letter J, well, let me see to analyze what was the cause of failure. In this case, the cause of failure because well done, well executed technique, and the failure was because early overloaded bone block and conjoint tendon. The problem is if this patient has a free bone block without conjoint tendon, did this pull up, push up or something like this could provoke a displacement or fracture of the bone? Could be not. The main characteristic and feature of this technique, lateral J, pull this patient to fail, who early overload his shoulder. Anyway, this is our analysis, because sometimes this is the first case I've seen even the cause of lateral J, not because they're bad execution, it's a good execution, good technique, well done technique, and failed. Because there's another one, it's not usual. And in 6 weeks, almost 6 weeks, it will be, I've seen many patients with lateral J doing with 2 screws, and screw is enough because this technique is very, as I said, good execution, and it will be healed at 6 weeks. In this case, it's like a little bit delayed healing the union between bone and glenoid. So this is what I'm a little bit, why this happened in this case. What do you think about why this case delayed the union at 2 months after pulling up?
I usually kind of go by the idea that it takes about 12 weeks to get bony union there. And that's why I don't let them back to sport before 12 weeks. I think certain patients have gotten away with going back sooner and maybe it's healed, but I haven't ever looked at a CT at 6 weeks. But you think about bone healing, I think most of them are probably not healed at 6 weeks. I think though, if you had a free bone block, then maybe you wouldn't have this problem of the conjoint pulling on it. And then if you had a different fixation but still a lateral J, if you had buttons but still a coracoid graft with a conjoint, would it have made any difference? It's hard to know. It's interesting. So I think while it's a really good operation, the traditional lateral J, sometimes some problems can be exposed. Anybody have questions or anything in the chat?
We have 2 questions from the chat. The first one is, would you add a remplissage in the revision case? Do you think it could make the difference?
Yeah, I didn't in this case. I have in similar cases of patients who've been sent to me with seizure disorders who failed a lateral J, because I think that just they need everything and I don't mind if they get a bit stiff. I didn't in him. I put a big iliac crest graft on the front and I felt he didn't really need it. If I was to do it, the way I did it in those epileptic patients, since I was open anyway, I sort of internally rotated them and snuck around and did it open. You could also do it arthroscopically. I don't think it's necessary. I'm not worried about him at this stage. He's healed his Eden Hibonette, so I don't think he needed it, but it's a good thought.
Great.
Ruth, from the point, sorry, Valentina, from the point of view of technically tips, how do you do it? Did you do it first arthroscopy, or at the end you close your skin and then arthroscopy, or in open fashion? Remplissage plus open lateral J.
Yeah, so what I've done with it in the past when I've done those epileptic patients, I've done it open. But I'm now, because we've started to add remplissage more often to the Bankart repairs, I probably would just do it arthroscopically because it's quite easy to do it with sort of two anchors and a pulley. I think I would probably do it at the end because I would take advantage then of the scope to look at my bone block and check the position. And then also if you're open and you put a humeral head retractor in at the back, you may crank on it and disrupt your remplissage. So I think it's best to do it after you've done your bone block at the front. That's
absolutely agree. For young people, if you are a fan of lateral J, open lateral J, do it. It's a good technique. And if you want to add it, it's a good idea to close the skin and put the scope. But at the end, is you can check your scope. Even you can reattach the capsule much better than an open way, an arthroscopic way. And then you can do remplissage after that. without a swelling. If you do it in the beginning, you're swelling tissue, so it's a little bit worse after that to open fashion lethargy.
Yeah, agreed.
Valentina, sorry, I interrupt you.
No, it's fine. It was really nice. The second question is, do you always check consolidation after 12 weeks before allowing athletes return to sport? And if you do it, how you do it? Like you trust the feeling of the athlete, you ask for X-ray, CT scan. What's your
Yeah, so where I trained in the US, everybody got a CT scan. My mentor, JP Warner, would CT scan all of his Latarjets at about 12 weeks, 3 months. When I moved back to Ireland back in 2014, the situation was that the insurance companies, the health insurance companies, wouldn't pay for CT scans of shoulders, and it's quite expensive for patients. And what my colleagues here were doing was looking at the Bernajot view, so AP and Bernajot and clinical and time. So minimum 12 weeks, good clinical exam, good Bernajot view, happy to let them back. And that's how I practice with all but probably the elite professional athletes. When they're going into that high level, I will usually ask for a CT scan. Or if I'm not sure on the X-ray that I can see consolidation or that I can really be happy with the position of my screws, like that kind of Bernajot view I showed you of the Aiden Hibinet where the screws looked like they were really lateral. And just a plain CT scan is the best way for me to look at consolidation.
Okay. We don't have any question. I think we can go ahead with the second case.
Dr. Ruth,
perfect.
I had a question from my side.
Oh, sorry.
Yes, sure.
Sorry. Yeah. Do you think you could have just done a remplissage and gotten away without doing a bone block revision?
Yeah,
Was that
maybe.
on your mind?
I guess I didn't want to risk it because he definitely does not want to have a third operation.
Yeah.
It's an interesting point though, because we tried to get away with the remnant of what was left of his coracoid on the front and then didn't get away with it, but he still had something on the front, like a kind of a free bone block, but a little bit smaller than what you might have put there if you had done a free bone block in the first place. So maybe adding a remplissage might have been enough. And I think, maybe if he had some problem with his iliac crest donor side afterwards, then I might have wished that we hadn't touched it. Thankfully, he didn't have those problems. And I guess because he's a collision sport athlete, I just wanted to,
Sure.
do a nice big bone block. But that's a really interesting thought, I guess we'll never know. If I would have it would have been an easier day at the office for sure. Put a scope in, do a quick remplissage. So possibly, but I didn't really think of it at the time. I just went aggressive.
Yeah. Thank you.
First of all, thank you again, junior committee, and for this invitation, Juan Aguilar also for the moderating. So let's go to this case, a similar case, quite similar case, but not it's quite young, 32 years old man, uncontrolled epilepsy, bilateral shoulder instability, was operated in left shoulder bunker alone in 2014, and then this bunker failed, and some elsewhere did open Latarjet 2015. So again, this Latarjet failed, and the patient failed felt little bit. It was a traumatic event, instability, shoulder dislocation, and several subluxation months after surgery. I look at X-ray. Always, I look at X-ray even for instability. Always. Why? Because like we see what happened sometimes. For recurrent instability, not after third shoulder instability, we lost some time. We will lose some time the anterior glenoid rim. So this is much more X-ray. This is the range of motion of the patient, 155 forward elevation, 90 external rotation at the side, interrotation 12, T12, and gauge test, abduction test, almost 135. That means the patient is lax, shoulder laxity, painful shoulder, apprehension, and his miserable OSES score and SSV score, and draw score 25. So with giving this X-rays, let me ask a question. What additional test would you order? Vinay from Australia. Did you ask for someone? Some X-ray?
Oh yeah,
Some more X-ray. What did you ask for?
CD scan
CT scan? Only CT scan?
and an MRI maybe, just to see what's going on.
With the screws? With the screws? It's good. CT scan is the best. But did you ask for MRI or CT scan, CT scan, CT arteriogram? Did you ask for some laboratory to rule out infection, inflammatory test, or not?
Not really, since he's epileptic and he has gross instability. I wouldn't think of infection, but it's better to rule out,
Not routinely.
not
Because if
routinely.
the patient doesn't have any symptoms of infection, scar, go to scar, no test.
Yeah.
Anyway, it's true. It's the best way if you have a screws. MRI is unless you have a good software to keep out the artifact from the metal. 3D CT scan, CT arteriogram, we can discuss about that, but CT will show many of information. So we did CT scan, here's the key, CT. So again, Ameer, could you describe a little bit to what you can see in this analyzing of CT?
I think there was still a line in the bone, so I think there's a little bit of non-union maybe. I don't know. Sorry, it flashed a bit quickly. I didn't quite catch it.
So, you know,
I don't know
yeah.
if you can.
I tried to go back. Now here, sorry.
No, it's okay.
Sky, lost by your face. This is what I'm trying to see your face.
Yeah, I don't. I mean, yeah, you can quite see on that 3D on the bottom right-hand image. There's multiple fragments. It's in pieces. It doesn't look like it's doing the structural job that it's supposed to be doing, really. There's quite a lot of bone loss on the anterior surface of the glenoid.
Exactly. It doesn't seem like quite huge glenoid loss. So what went wrong here, and how do you assess shoulder laxity? I mean, it's important for me to assess every single laxity because I have seen many lateral jet failed lateral jet because the technique was bad executed. The graft test was a little bit high, so the patient comes pop up down between 4 and 6 o'clock because and sometimes laxity, shoulder hip laxity was as you can see here. This is a piece of bone. The piece of bone is a little bit very high, as you can see here. So almost from 4 o'clock to 3 o'clock, it's like no piece of bone there. Of course, the length of screw is quite long. And if you look at the CT here, it's like at 1 o'clock, even the most highest screw, and the second one is like at 3 o'clock. And so down, the shoulder pop up and dislocated between 2 and 4, 5 o'clock. So this is what happens. This patient was lax. So this is what we should assess every single laxity of the shoulder. So how we can do it? For my side, I always don't use Baker score because from this has been demonstrated from this paper is useless because if you take a look at the 5 items of Baker score, there is no one assess shoulder laxity. So how we can assess it? This is like gene Walsh test. This is like if you take a look at the ER1 more than 85 degree and even hip abduction test more than 120, and this patient has very hip laxity. But remember, some patient like this woman is normal shoulder. If she has this one shoulder hip laxity in the axillary without any symptom, is like normal shoulder. So having said that now, this is what kind of treatment option you can see. We can have a revision here because it's like quite big piece of bone in the upper part with a small bone down. We can do it, remove it and refix it down, give it this laxity. This is another case. Maybe keep it all this kind of. We can remove all the screws and then go to the axilla, placate the axilla, and add in remplissage. Or third option, open revision with free bone block, even distal tibia or autoiliac crest bone graft, all arthroscopic screws removal, and with all arthroscopic free bone block. What do you think? Blanca from Madrid.
So I think, as you have said, hyperlaxity is very important, but the main problem from him here now is that there is a huge glenoid bone injury. So I think I will go for an open revision. I will remove the screws. Also, I will like to see how the subscapy is and check all the nerves with an examination, I mean, not surgically. And we will revise it even with an adenine vignette or a free bone block. We normally don't have access to fresh bone block, so we normally have access to frozen. They are less quality, so probably we go for a iliac crest. And after fixation, we probably add application to assess hyperlaxity. But I think the main problem here is the glenoid bone loss. I don't
Did
know
you
if you
check
agree.
in? Sorry?
I don't know if you agree that.
Okay, no, it's a good idea. No, of course, we need to revise this one. I mean, you can do it. I put these 4 options because someone decided as I was a guy from Australia said, let's go to try to placate. But given this length of the screw, it's like it's damaged our eyes to keep it there. So we need absolutely to remove this screw. If we want to remove this screw, and you should do open or arthroscopically, and you can add it something like that. What do you think, Ruth?
The other thing I'm wondering is, he looks even on the x-rays like he's started to develop quite significant degenerative change in his glenohumeral joint. Does that change or influence your decision about which of those procedures, you're going to choose? It looks to me like he's got some joint space loss. He's got some inferior osteophyte formation on the humeral head there, and he's 32. He's not stiff because he's hyperlax, but do you maybe go for a procedure that has no metal or less metal because of the fact that he's sort of on his way to developing arthritic change there, or does that change things for you?
Very good point of view. It's like Samuelson type 1 or type 2, even this is osteophyte, and the cartilage was a little bit damaged also. If this is what we have, we know that recurrent instability provoke and from the beginning just changes. So it's a good point to avoid metal. Absolutely agree with you. And absolutely agree with you to even avoid the hard body metal, to go to soft anchors. But in this way, my first issue was to have a good window to start it to do this surgery without any problem for recurrence instability during the seizure. So the first we should keep in mind this patient has epilepsy, so we should be sure that at least we have a window time to heal the bone graft or to heal even the soft procedure if we don't want to perform any procedure. So we should take with this patient, take care from the neurologist to keep in mind this. They took this capsule, they treatment the drugs for 6 weeks and 8 weeks, at least to have at least no seizure from 3 months, to have pretty sure that all these procedures, whatever you want to do to heal this bone and this soft anchor or soft procedures. Another point of view is what kind of graft. So this is a failure autograft iliac lethargy. So what do you prefer now? Iliac crest autograft, distal tibia from the bank tissue. So this is another problem, another issue to decide, because they say we wouldn't have to have one chance. So Bahadir, what do you think about it from Turkey?
So iliac crest is a good option for now, like a last case. DTA, we don't have DTA in Turkey, so iliac crest or distal clavicle allograft would be good options for us for this case. This is my opinion.
Distal tibia.
No, distal clavicle
Distal
allograft.
clavicle, sorry.
Yes.
Have you used it? Have you used it one time?
I'm sorry?
Did you use it? Or I mean, you hear that from the literature or you use it?
No, I never use it. So it's from literature.
So my problem is like in this kind of 30 years old, it's like cancellous bone, not weak, not a strong bone, And at the time, maybe if you want to use one screw, even that technique published and as a revision for Pascal, that you one button, it could be enough. But if you have a big, huge bone loss, as this case, you need bone. You need to restore the anatomy. So would be in my thought, like distal clavicle is very thin, not too big, so you cannot restore the anatomy using this technique. You should be sure that if we restore the anatomy, you need, as this one, a huge bone defect, a huge graft.
Okay.
I want to ask Juan, what do you think, Juan? Because you are moderating here, but you can also participate as a panelist.
Yes, of course. I think in this case, we have a non-union of the graft. Probably the scissors have been some of the reasons of the failure, but we have bone, and also we have the conjoint tendon there still, and we can rescue it. So it's tempting to try to keep the bone or at least some piece of the bone and keep the conjoint tendon. It's true that the patient is hyperlax, so the effect of the sling of the conjoint tendon maybe is less useful at this case. But in my opinion, I would go with plan A. If the bone is good, maybe I could use the bone or at least try to rescue the conjoint tendon, but for sure I would keep my more reliable plan. That would be to have a big piece of bone of the iliac crest that I think is the gold standard. It's viable, is there, and it's gonna heal, and it's patient's bone. So Ederminet with a big block, but also depending of how I find the bone and the conjoint tendon, maybe it's a good idea to keep it. That would be my two options. It's the difficult case.
No, it is what my thought was, but the problem is, my doubt was, it is one piece of bone or 3 pieces of bone. It's like if you take a look at this CT scan, I saw the CT scan many times. I wasn't sure that this is a piece of bone could be reattached, because here in the most lowest part, maybe the conjoint tendon here is with piece of bone. This is a screw, then another piece of bone. Anyway, I decided to revise this case by arthroscopically. This is a lateral decubitus, superior view. I tried to find what very tough one. Almost it took me 45 minutes, 15 minutes to find this screws, and to keep a little bit to remove the bone around this screw. It was very high position, and remember this case was done by open surgery. So the scar was very medial in lateral decubitus. Hopefully, I could remove all this, both screws from the anterior percutaneous portal to remove. I remove it from screwdriver, and then from the interval portal, I removed the screws, as you can see here. The both screws. It took me many times. So after that, when I remove these screws from the joint, I perform our technique. It's well known now, bone block cerclage. We published this year. The last first series was published in AGSM 2 years ago, and the last one we published in arthroscopy this year. So I detach all the capsular blood complex. Believe me, it was not easy, but I go in the upper part, but in the axillary part, it was very easy to detach the capsule. I introduced a big iliac crest bone graft from the patient, and I introduced it through the rotator interval. I use our technique published with suture cerclages from backside. We performed this 2 tunnel from back to anteriorly with a pre-made guide. And then this is my finger here. We can introduce our finger to adjust the graft, and then we reattach the capsule. Look at this anchor. My lowest anchor is like at 5 o'clock. I reattached at the capsule. Look at the capsule. Is very. If you go as the capsule to the axilla, you can see the capsule in the axilla. You can reattach the capsule even after Latarjet, because the surgeon goes, in this case, in the upper part. I reattach the capsule and keep the graft extra-articularly. And this is the highest suture done at almost 3 o'clock. I use in this case, the lowest anchor was fiber tack, like all suture anchors, and the highest anchor was like this is bio impacted screw. At the end, I checked the stability was pretty well and good during the surgery. And at the end, I always perform CT scan for all my patients, pre-operatively, post-operatively, always, and 1 year. So this is, look at the graft, how it's big. It's like a new shape of the glenoid. This is upper part, and this is the lowest part here in the axillary view. So we try to keep it a little bit as much as possible flush to the until we do the concavity. And then this is the patient 2 years after, with a good healing and good shape of the glenoid, mini glenoid, with remodeling. And the patient is now, this is like almost, now he has 3 years after. 3 years after, not 2 years. Of course, he has degenerative changes, as Ruth say, but he's happy, quite happy. He has a little bit mild pain, but very stable, good control of epilepsy, and he is very happy. Any comment?
That's really nice, Hachem. It's such a dramatic difference from the first graft to your second graft. It looks fantastic.
Absolutely agree. I think it's a good idea to have this kind of tool, no metal in revision, because you can revise as you did. It's a good job also, but it's different kind. It's like you should keep in mind. I always use classes because I'm a fan of my classes is to free metal, because I can even, if you cannot do a CT scan, you can follow this patient with MRI. And absolutely, I remember my first case, I did MRI because our IRB doesn't allow me to control this patient with CT scan. It's not about money. It's about we cannot do it too much CT scan, even for shorter slices, because I need only at the glenoid side. So then you cannot do it. So at the end, I asked for MRI, and I could follow with MRI this patient at least at 6 months after surgery. Anyway, it's a reproducible technique. It's an anatomic way, because we introduce the graft from the rotator interval. It's not. I mean, we can be done for any single surgeon with a little bit advanced surgeries, not from the beginning. Of course, as junior, we need to have a little bit move from bunker plication and remplissage, and then try to start it with the bone block as free metal or Latarjet. This is much easier than Latarjet arthroscopic way. If you are fan and believe in arthroscopic Latarjet, don't do it quick and faster. This is deep learning curve. Ruth published about the complication in the beginning and learning curve. So your junior, go, if you decide, whatever you decide, do it in open fashion. It's easy. And when you feel better, comfortable with your skills, doing bunker plication, anterior, posterior, axillary, and then even remplissage, and then you can decide to do whatever you want in free bone block or Latarjet. But this is my advice to you guys.
The other thing that's really
Valentina.
nice about your fixation, I think, as well, is if he has another seizure down the road, it can be such a mess if they have a seizure and they break screws and it's a complete disaster trying to sort it out. You have no metal in there to deal with if the worst happens. So as well as the fact of the arthritis and maybe having to do some arthroplasty later, it's such a nice technique for these epileptic patients to not have screws in there too.
Absolutely agree. I have another patient, I wouldn't put it here. At 4 weeks after surgery, he started to seizure. So the bone wasn't healed. And he disrupted a little bit the graft immediately, but the graft was attached and in medial, very medial. So I followed the patient 6 months and advised him to go to the neurologist. And 1 year after, I revised him. I cut it this tapes in 5 minutes, and I kept the bone was healing very medial. I keep it there as a balcony. I put above this graft another graft, and I mentioned now you cannot have a seizure for 6 weeks, 8 weeks at least, because you cannot have. We should have time to union between bone graft and glenoid. So this is for revision is good, and this type of patient for seizure is advantage, an advantage one.
Very good case. I think Ameer has a question. Go ahead.
Yeah, a couple of questions actually. So, with a patient like that, epileptic with, instability, long time history, how long would you have to wait for them to be seizure-free before you would operate on them? That's my first question. And the second one is how do you fight the swelling inside the shoulder when you're doing such a complex case arthroscopically, like you said, taking the screws out, etc., took you 45 minutes, then you started the case. So, how do you fight the swelling that comes with that?
So at least we need 3 months, 3 months without seizure. And then other 3 months at least. I mean, a window, I keep the patient 6 months. If patient has 6 months before surgery, no seizure, that's good because it will be 3 and 3. So I keep it 6 months at least. So for the second question, it's a good idea. But remember, when we are using a free bone block, we cannot have like all the cannula with cannula. We should introduce it without cannula, even with a finger. So the water is go outside all the time. It will be swelling, but not too much.
Thank you.
May I ask you, you haven't had a remplissage in your case, right?
No, in
No.
this case, I didn't.
So my question is, since the problem looked to me on both sides like osseous and it was a lax patient, so even the soft tissue was affected. I've seen that you use the capsule just to cover your graft. Do you think that adding the remplissage could
Remplissage.
change? Yeah, everything,
Yes,
or
absolutely.
maybe you did this choice because there were already like degenerative changes, so the balance of the joint could have been affected.
A very good question, Valentina. In fact, this case was done 4 years ago, but in my last 2 years and a half, now I'm adding remplissage for every single shoulder instability with soft procedures. Why? Because I believe it's not all about the anterior stitched capsule and the axilla. We should push back and pull back the head. So I realize now the anchors the same. If we can placate the inferior capsule, we can placate the posterior capsule even by introducing the anchors from very lateral. If you introduce your anchor from very lateral in the heel sac, not like this one. Remember, this is the cartilage here. This is the heel sac, posterior heel sac. So if you put your anchor very close to the cartilage, no. In the middle, this is the true way. But instead of going in this way, if you introduce it from very lateral, that means you shift your lateral capsule to the heel sac. And you don't lose any external rotation, and you pull back the head of the humerus. This is my point of view now. And this is what now I'm doing for every single patient without any restriction of external rotation loss. Even in some cases, 5, 7, 8, 10 millimeters. And patient in this is if you compare, and he lost 5 millimeters, 5 degree, unless we are not talking about throwing athletes like tennis player or a pitcher. I think it's every single, even patient with coalition athletes, contrast athletes, they feel much better and stronger in his shoulder than before because it's very tough. And immediately they can start it at 2 weeks after surgery, even with soft procedures, by adding remplissage the rehab, early rehab.
Great, thank you.
Ruth.
Yeah, I just wanted to ask you, Hachem, so you said you're adding that to every single patient. Do you mean, this might be a crazy question, do you mean only the patients that have a Hill Sachs, or do you think there's any role for your theory of pulling back the humeral head in patients that don't have any Hill Sachs lesions? Say you're doing just an arthroscopic Bankart and you want to give them extra stability. Do you think there's any role for doing something sort of non-anatomic when there's no Hill Sachs? Because for me, if I see no Hill Sachs, then no remplissage. But where do you stand on that?
To be honest, I only can't see heel sac in the first shoulder dislocation. In very hip relaxed patient, they don't have even in very hip relaxed, no heel sac. In this kind of patient, I saw one patient last year. Believe me, I'm doing now much more instability than cuff. I don't do cuff. I don't know why. People send me instability. last year, I only saw one patient, first instability, because he has very semi-professional one, 16-year-old. I do for him first repair at the third dislocation. He doesn't have any heel sac. So in this case, I placate the capsule from the axilla. But for all majority of patients, and most patients has at least on-track lesion. Not all, I'm not saying off-track lesion, even on-track lesion. I put my lateral two anchors, my pulley. I publish my technique is a bridge technique from very lateral to avoid this through anterior translation and put under pressure the anterior repair and the anterior capsule. I feel my patient now. It's do it. I believe that I want to publish my result because it's true, because the capsule is stretched. So once the capsule is stretched, it's not normal capsule. So it's stretched anteriorly and posteriorly. So shifting by lateral to medial in the heel sac is the same. You can get the same effect, stability, and much more stronger.
Yeah, it's interesting. I think, it's a good point that probably if we look hard enough, almost every recurrent dislocator will have a heel sacs, but sometimes with the scope in the shoulder, you may have to externally rotate the shoulder a little bit to see an on-track heel sacs lesion that's kind of small. So I think that's a really good point. Can you also tell us, you mentioned something when we were at the SETCH meeting back in Valencia a year or two ago, you talked about the position that you have the arm in when you tie your remplissage. Is that still an important factor for you? Because I really liked that point that you made.
Yes, this is a good point of view. To understand the remplissage, you should put your camera independently if you have bitchy chair or lateral decubitus in such anterosupralateral portal. Because if you put your anchor in the anterosupralateral portal, you can see the down, like glenoid side, and then you can go anteriorly and posteriorly to heel and even in reverse heel sac for multi-induction stability. So in the beginning, my thought was to rotate the shoulder. Why? Because when you rotate the shoulder, you can see how you can put your posterior capsule stretched or wrinkled. So if you a little bit rotate internally your shoulder and push anteriorly, your assisted surgery pushes anteriorly, so you have your posterior pouch, you can test how is the laxity of your posterior capsule. So in this position, I introduce my needle to see how many capsule I capture from posterior back. So needle comes from lateral, and I push down the capsule and try to attack my insertion anchor in the posterior heel sac. That means at the end, if you take a look at from the insertion from the spinatus capsule to the entry point of the nail, it's like less than 1 centimeter, 7 to 8 millimeter, because you feel the capsules comes down. So by putting your shoulder in which position, you can assess the relation between the capsule and the head and the heel sac. This is what I mean.
Thanks.
We're reaching the end of the session, but before we close, I would like to thank all the speakers and the panelists for their excellent contributions and for making this enriching discussion possible. We have learned a lot. I feel like it's been super useful for young surgeons to learn this session as always. So thank you very much, and a special thanks to the senior surgeons participating today. Just 3 quick points before we are closing. First, I encourage all the junior surgeons interested in case-based discussions like this to apply for future OSES sessions, which we will continue throughout all the year 2026. You can apply scanning this QR code, and also you have the link on the chat. Second, we also invite you to join the SESEC community. If you are a young surgeon under 32 years old, it's free. It's a free junior membership, so do not hesitate to join if you are into shoulder surgery. And last but not least, a reminder that the SESEC Congress will take place in Barcelona from 2 to 4 February 2026, and abstract submission is still open. The deadline is in the 4th of February. So there is still 1 week left. So go and submit your abstract. That's all. Thank you all for joining again, and see you in the next OSES session.